Well, hello, everybody. It's 2 o'clock. I want to welcome you all to our ATOM webinar today. And it's in the You Asked For It series because you asked for it. And this webinar is going to be about advanced strategies for DRGs, inpatient status appeals, and then we're going to talk about Medicare Advantage a little bit, tackling non-compliance for Medicare Advantage payers with the 2 midnight rule. So we've got lots of material to cover, so we're going to get going. So, okay, advance to the next slide, please. You should have a little place here where you can open up your control panel, join the audio. There's a place where you can download handouts, and you can submit questions and comments via the questions panel down there at the bottom. And we will make every effort to answer as many questions as we possibly can during at the end of the program. Advance the slide, please. A little bit about ATOM. ATOM is the Association for Healthcare Denial and Appeal Management. It's the nation's only association dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals like you working in the field of healthcare insurance denial and appeal management through education and collaboration. And our vision is to create an even playing field where patients and healthcare providers are successful in, I love this word, persuading medical insurers to make proper payment decisions. There's a website there for atom.org if you'd like to see more about our organization. And I would be remiss if we didn't say that ATOM was created through the generous support of PayerWatch. Next slide. So just a little bit about PayerWatch. PayerWatch is divided into several sections. We have PayerWatch AppealsMasters, where thousands have been trained in denial and appeal management, strongly believe in the clinical legal approach and taking your appeals as far as you can possibly take them. PayerWatch Veracity is the software side of our company. It's a leader in the denial prevention industry, and it was created to be in service to providers in protecting revenue. So if you would like any more information about PayerWatch, there is a website there for you. Next slide. So CEUs and contact hours. Free CEUs are, as always, offered only to ATOM members. And to obtain the CEUs, you must be an ATOM member, attend the live webinar for at least 53 minutes, and complete the survey. Those are the 3 requirements. There is more information on this slide. Please read it at your convenience. There's information here that if you don't receive a CEU or your certificate when you're expecting it, there's a couple hints to check on. And if you don't have the problem resolved within 30 days, then let us know, so we can try and help you figure out what's going on. Next slide. Okay, today we are happy to say we can give CEUs from ACTUS, NARI, CCMC, AHIMA, and the ANCC through the NEMSD, the Northeast Multi-State Division Education Unit. Next slide. Disclaimer, and I do need to read this in its entirety. The Association for Healthcare Denial and Appeal Management, or ATOM, publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all ATOM members. ATOM does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by ATOM members in conjunction with other research deemed necessary in the exercise of ATOM members' independent professional judgment. ATOM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials' authors, do not necessarily represent the views of ATOM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. Next slide. Now, we have 2 sets of learning outcomes today. They're very similar, but they are for different certificate giving organizations. So at the conclusion of the webinar, the learner will be able to determine factors that influence DRG assignments and identify critical components of compliant appeals for denied inpatient status. That is for the AANC and /NEMSD for nurses. Or at the conclusion of the webinar, the learner will be able to self-report. They can pick out one factor that does not influence DRG assignments, select one critical component required for a compliant appeal of denied inpatient status, and identify one common scenario where Medicare Advantage plans deviate from the 2 midnight rule. Sounds a little bit like that. These might be evaluation questions. Just saying there. So, okay, next slide, please. And very happy to have Dr. Kendall Smith with us. Yeah, there he is. There he is. He's quite happy to be here.
Overly caffeinated, but we're happy. So, yep.
Yep. Okay. And then, yeah, you can go to the next slide. And then there's me. So, yeah, you can read about both of us if you like. Okay, next slide, please. All right, let's get to it. DRGs and hospital revenue beyond the basics. All right, we know that that most of you have some background already. This is not necessarily a beginning information here. So we're going to talk about the case mix index. Just as a refresher, the CMI is a measure used to reflect the clinical complexity of the patient population treated in a hospital. And the way the CMI is calculated, you take the average of the relative weights of all the DRGs for patients treating during a specific period of time. There are relative weights associated with the DRGs. These weights, these numbers are assigned based on the resources required to treat patients within that group. And the bottom line is, as there are increased complexity of cases, there's going to be an increased use of resources. The more increased use of resources, in theory, the higher the DRGs, the higher the CMI, the higher the reimbursement, and that is why it has a direct influence on the financial health of the hospital. So these things are all very, very important. Next slide, please. So some of the factors that influence DRGs, and there are many things that influence DRG. Documentation in the medical record, which ends up being the principal diagnosis when it's coded, different surgical procedures, patient age, patient gender, and reimbursable comorbid conditions or CCs, and major comorbid conditions or complications, MCCs. Accurate coding is a huge factor in getting the correct DRG. Queries are of utmost importance. So the CDI and the coding folks, you have to be very, very cognizant of when you need to query. And just as a quick reminder, whenever a coder codes a medical record, the diagnoses are turned into codes. Those codes are entered into an encoder, and the encoder comes up with the appropriate DRG. So it's all based on the documentation and the coding. Next slide. All right, so let's just talk a little bit about comorbid conditions. Not every comorbid condition that a patient has is reimbursable, and that can come to a huge surprise to the physicians involved in the care. So some examples: CHF, anemia, respiratory distress, and there are others that are examples. Those are not reimbursable comorbid conditions. So it's got to be the right language. So instead of CHF, if it can be specified whether it's systolic or diastolic, then it becomes reimbursable. Acute blood loss anemia, malnutrition, hyponatremia. Major comorbid conditions and complications, or MCCs, if diagnoses can be specified even more, and supported by the medical record, of course. Acute systolic CHF, acute respiratory failure, severe malnutrition, hypovolemic shock. These are all things that are considered, and many more, considered MCCs, and they do change annually. So you want to stay on top of those. Next slide. So CCs and MCCs, it's not all about the money. It's not, it really isn't. And Kendall, this is your slide. Do you want to?
So I'm going to jump in here and get on my soapbox. So my philosophy with documentation, the revenue cycle, and tying all of this together is that quality documentation drives outcomes, outcomes drives dollars. We should never be documenting for dollars. But when we're looking at the impact of documentation on outcomes, this is a great slide. The data is a little bit old, but the math still holds up here. So if you go through the math here and say you have a hospital in the course of a year admits 100 85-year-old patients with hip fractures, all 100 of them have acute shortness of breath, and they have 2 deaths from, just by virtue of being 85 or 90 years old. Going to the OR under some form of anesthesia is a huge stress. 1 or 2 deaths in that group, just by virtue of age alone, wouldn't, I think, take a lot of us by surprise. What does that mean? That's a 2% mortality rate. What you see labeled MORT, more short for mortality rate on the right, is what CMS's actuarial data predicts for that DRG based on the documentation in the chart. So if all of these 85-year-old patients come in and then postoperatively develop what the hospitalist, intensivist, anesthesiologist, or orthopedic surgeon says acute respiratory failure, suddenly they have an increased need for oxygen, something triggers it. Hospitals providing resources to treat this. Depending on how this is documented, one doctor comes along and rates shortness of breath. The other patient, they said, well, we know the patient's got a history of COPD. They're on 2 liters. Doesn't take note of the fact that they're now on a venti mask, or they may be on 8 liters or 6 liters postoperatively, which is a significant abrupt deterioration, suggesting an acute decompensation of a chronic condition, and just documents patients on oxygen has a history of chronic respiratory failure. The expected mortality in that case is still, out of the 100 patients, you would be expected to have less than 1 death as the attending physician in the hospital. So if you're documenting that the patient developed shortness of breath and required significant oxygen postoperatively, and you're not connecting to the dots, saying this patient had an acute decompensation of chronic respiratory failure, your 2 deaths in that year, 2% mortality rate, is about, what do we figure that math was? I'm horrible with math, Karla. 8, 10 times, 10 times higher if you're just documenting shortness of breath. Actually, it's about 10, 15 times higher if you're documenting acute shortness of breath. So you have gross excess mortality. They're keeping track of outcomes for physicians. They keep track of outcomes for hospitals. And in fact, CMS bonuses hospitals based on their actuarial data, mortality, and other things. But if your physicians, providers are adept at picking this up, and they know the magic language to say, my patient had acute on chronic respiratory failure, your 2 deaths out of 100, your 2% mortality rate, you're actually rocking as a physician and as a hospital, because CMS expected that 1 out of 15 patients that you would take to the OR under that condition, with those conditions, was going to die. I mean, it's pretty frank and a graphic discussion, but the math is the math. And so this is the impact on that. And then when you look at the reimbursement that follows from good quality documentation, we often see differences of between $10,000 to $20,000 on surgical cases when we're talking about no comorbidities versus a major comorbidity. This is why major comorbidities are so targeted by auditors. From the auditor's perspective, it's not a question of quality, it's a question of financing and finding the money, recovering and going after the money. From the hospital's perspective, they want to provide good quality care, they want to demonstrate the true acuity of their patients, and they want to be paid appropriately for the resources they're using. The only way to connect all those dots is to get the language exactly right. But MCCs, by virtue of the money that's attached to them, because it does indicate a significant use of hospital resources and risk, these are prime targets for auditors, and these are what we so aggressively appeal, and we see more coming in more and more frequently. So enough, I'll get off my soapbox, shut up, and turn it back over to Karla.
No, I agree with you 100%, and I really like how you made the analogy. And what I used to say when I was talking to physicians about this is, you don't want to upcode, but at the same time, you don't want to downcode. You want everything right where it's supposed to be, because everything is going to fall in place. Those scorecards for the physician, for the hospital, the reimbursement, it will all fall in place. So yeah, I agree.
Get the appropriate credit for the patients you're taking care of. If you are over documenting conditions that don't exist, if you're calling, you're going to be an outlier, and someone's going to come looking at that just as much as they're going to come looking at audits. So, you know, CDI programs are invaluable in helping to ensure that the documentation's appropriate, accurate, needed, and justified based on the circumstances. So enough, I'll get us out of the weeds and shut up.
Next slide, please. Okay, so let's talk a little bit about DRG and DRG payments. So sometimes you want to get an idea of what the DRG is going to pay, or why it's paid the way that it is. So here's a quick way that you can sort of figure that out. As you know, there's numerous influences on the DRG payment. We talked about some of them. But there's also a base rate that is assigned to every DRG. And that base rate, the money figure, there's additional monies that are added to that to different hospitals, and it varies hospital to hospital based on complexity of the cases that they have, the geographic location. Are they teaching? Are they non-teaching? Disproportionate share adjustments. You know, those are just some of the things that influence the DRG payments. So in 2024, the base rate average across the country was $6,497, just the base rate. So like we talked before, if you multiply that base rate times the DRG relative weight, and you can find that CMS has a table called Table 5. I've even Googled just CMS Table 5, and you'll land on the right page, so you can find out what the relative weights are. That will give you a conservative estimate of the DRG payment. It's not going to be exact, you know, so don't take that money to the bank, but it's going to give you an idea. So for example, in one of Dr. Smith's examples, the relative weight was 1.5. So if you take that base rate of a little over $6,000 times the relative weight of 1.5, a conservative estimate for that particular DRG would be a little over $9,000. So that's how you can do just kind of a quick figure out what the reimbursement's going to be. Next slide. Let's talk a little bit about DRG audit downgrades. And I think you're all familiar with what these are. We see them every day of our lives. And up until recently, we used to consider there were 3 kinds. Now we consider there are 4 kinds. And thank you to Dr. Smith for we talked about this just the other day about the 4th kind. I hadn't really considered it till we talked, but there really are. So the first kind would be coding. And if you've been in our webinars before, we have talked a lot about the differences between coding and clinical validation. We're not going to go down that rabbit hole today, but just very basically, the denial letter, if you simmer it down, it says coder, you coded it wrong. It has nothing to do with the clinical scenario. The denial is based on coding guidelines. So you're going to need to appeal with coding rationale, coding guidelines. You prove why the original coding was correct. And there's an example there. A diagnosis was being resequenced as a principal diagnosis, another's being resequenced as a secondary. That is coding, nothing to do with clinical. Clinical validation, they're essentially saying, doctor, you misdiagnosed your patient. Doesn't have anything to do with the coding, based on clinical criteria. So you want to appeal with peer-reviewed clinical criteria and clinical resources. Prove why that denied diagnosis was correctly diagnosed. So an example might be acute respiratory failure was denied because the respiratory rate was, that's a clinical factor. No ABGs were done, again, that's a clinical factor. Lowest SpO2 was 95, clinical. No high flow oxygen was needed, clinical. So that's a clinical validation. Next slide, please. Okay, the third is, we call it dual denials. It's both coding and CV. So it's a combination of the 2 that we just talked about. Coder, you coded incorrectly, and by the way, doctor, you misdiagnosed your patient. So you have to appeal according to how it was denied, why it was denied. So it was denied because of coding and clinical rationale. So you need to appeal with both coding and clinical resources. Prove why the denied diagnosis was coded correctly and why it was diagnosed correctly. So you've got to read them carefully. An example would be acute respiratory failure was denied for all those clinical reasons, and then acute systolic CHF is denied because it wasn't documented in the discharge summary. Or maybe it's just one diagnosis and it's denied for clinical reasons and coding reasons. You have to appeal with both. And here's the fourth criteria. And we're going to talk more about this when we're talking about Medicare Advantage coming up in not too long. Payers are using their own proprietary information. And coders and clinicians, you know, we don't know what it is. We don't know what they're using for criteria. How many of you have seen that modified SOFA criteria? You know, you can't measure this level until after hydration. Framingham criteria to diagnose CHF. This is one of Dr. Smith's favorite pet peeves. Did you want to speak to that just a little bit about the Framingham?
So we've had a sea change where insurers are defining their own criteria, as Karla had said, and this started with Sepsis 3 United saying that they were going to, in 2016, 2017, start to define sepsis clinically only according to SEP 3 and disregarding SEP 2 and any previous diagnosis and their clinical validation audits. I then came across a clinical validation audit from Humana saying that Humana was only going to endorse a definition of acute heart failure based on Framingham criteria. So those of us that have as much more gray hair than I do would recall that the Framingham criteria are over 50 years old. You date from the early 1970s. They do not contemplate any of the current features used to diagnose heart failure. An ejection fraction, echocardiograms probably weren't even around in 1972 when the damn thing was developed. BNP, which we use as a lab value to support the diagnosis, didn't exist. Instead, it includes things like 5-day hospitalization, loss of like 6 kilos of weight, bilateral edema up to the thighs, and it just goes on and on. JVD up to the ears, things that, you know, my generation of physicians before me would have been used to documenting, but our current generation of practitioners, it would not feel comfortable or natural for them to document in that style. Nonetheless, Humana reserved the right, based on these audit letters, to say that this is how we're going to define CHF, and they started to audit some of the hospitals we work with abandon using that definition. The only way to fight that was to educate the clinicians, the CDI staff about this, and provide an alert to the CDI staff that this was happening. And when you had a Humana patient, you probably needed to stop and be aware of it, and ask the doc for some additional information that they wouldn't otherwise have put in the chart at the time. So very, very unfortunate world. It doesn't align with how we clinically practice, but it does exist, and the payers under their contracts are entitled to do it until we tighten up the contracting process.
Yeah, and that is, thank you. And that is exactly why we have as a bullet point under here, check your contracts. Get involved with your contracts. Do you even know what's in them? And I get it, it's hard. It's really hard to get access to them. Keep chipping away. Try to have some influence in what your contracts say, because it can make a huge difference.
And I think the other thing, Karla, I'm just going to jump in, and it's pardon for the interruption. I think one of the things for the audience to remember is you're actually the eyes and ears of the front line of the revenue cycle. Even though we're dealing with denials for care that was provided a year and a half ago, if you start to see new and strange rationales for denying care, let your manager know, have a discussion with the CDI program or your physician advisor, because the odds are that this means that payers have evolved a clinical definition, and you've got access to that information. You're the first set of eyes that are seeing this, and you should escalate that so that the hospital can decide whether that's just under the contract that they have with the payer, and or educate the CDI staff as to how the hospital is going to anticipate that going forward. But the last thing you want to do is let the strange rationale slide by, because that means there will be more of them coming. You know, for the last 20 years, the term clinical documentation integrity, originally it was clinical documentation improvement, but it's, I think the more appropriate term with I is integrity, because we want to make sure that the documentation in the chart actually reflects the conditions that were treated in the hospital. So we're looking at integrity or honesty and trueness in it. And unfortunately, with payers getting creative with definitions and then using that as ammo to come back and audit these charts 12, 18 months later and recoup significant amounts of money, we're starting to shift from an era of clinical documentation integrity to payer, I hate to say the word, but payer documentation integrity, where you need to be aware of who the payer is, what clinical conditions being documented, and then audit proof the chart at the time the care is being delivered. Yes, the patient has CHF. Yes, it's acute CHF, but we know unless we include a few archaic terms required by a certain payer, that this is going to be bait for an audit 12 or 18 months down the road. So let's take the extra time while we're here to get some payer specific terms in the chart to survive that audit 12, 18 months later. These are high dollar take backs, or the organizations need to pivot and start to anticipate this behavior spreading. It's expensive, and it can be prevented once it does happen.
Good information, thank you. Okay, next slide. I'm going to talk some more about appeal strategies, but first and foremost, and if you've come to our CV or coding webinars in the past, you've seen this before. Never, never, ever believe that the payer's rationale is correct. You want to really look at that. Don't just state the facts of the case. Scrutinize every reason given to deny. Push back at everything that's not correct. I think your win rate is going to be, your overturn rate is going to be higher.
More erroneous rationales, Karla, that my belief is are being generated by AI. We know the payers are aggressively embracing AI. In fact, there was an article in Becker's this morning that the Medicare Advantage Plan spokesperson wanted to sort of push back on some of the guardrails about the use of AI in decision-making and audit process that Medicare had put in place. So it's clear that the payers are rapidly employing AI-based solutions. And with that, I think comes an extra level of scrutiny about what's coming across your desk. But as Karla said, read every letter, and I actually read them with the assumption that the facts that are incorrect. And then first thing I do is to go through and verify the facts as they're being put forward. And then once I check those off and make sure that the facts are true, and then and only then would I proceed with it as an audit or denial.
Yeah, that's exactly how I do it too. I go in with the presumption that some rationale is wrong. So, okay, next slide, please. Okay, so just a little more about what we just talked about. Do more than just state the facts. Justify your appeal with direct rebuttals. And here's a scenario. We see it all the time. Sepsis was denied because it didn't meet SOFA criteria. But once we looked at the medical record, not only was SOFA criteria met, sepsis 2 was met too. So here's just a little excerpt of some of the direct rebuttals. It should be noted that the auditor erred in dismissing the patient's shortness of breath, low O2 sats, resulting in low PF ratios. No other respiratory conditions were present to account for this acute change from baseline. Likewise, the auditor failed to account for the patient's hypotension and low MAP values. So just ignored that those things were there. Furthermore, the auditor erred in claiming the platelet values are only determined after hydration. And went on a little more about that. Then the patient's total SOFA score came out to be a 5. And it was explained very well and why it was a 5 in the actual appeal. Thus, the patient met every consensus-based criteria for sepsis, thereby validating the diagnosis in question. So every erroneous statement, go after it. Next slide. So here's this is an important statement, and it comes from Coding Clinic, 4th quarter 2016, and we see it in many denial letters. Only they don't have the entire statement. You will usually see a payer may require that a physician use a particular clinical definition or set of criteria when establishing a diagnosis, and then they stop. Okay, but that is a clinical issue outside the coding system, and if you think about it, yeah, that it is. But the other thing is a facility can also require their own definitions as well, but they don't like to say that part.
And it doesn't say that one trumps another, nor, and most
No.
contracts are silent on which one. So they really put their thumb over this, and it's misapplied, it's misused. And there have been a lot of post editorials and comments on this. And I really wish they'd come out and clarify this, because it's probably the biggest misapplied and misused coding clinic out there. And it really does need to come back and be addressed.
And there's a lot of implications for that too. Provider document is paramount, because diagnosis codes are assigned based on that physician's documentation, regardless of clinical definitions or criteria. Coding versus clinical judgment. Clinical definitions are not, don't dictate coding decisions, and vice versa. Facility and payer influence. Facilities and payers may enforce their own clinical guidelines for operational purpose, but does not alter coding guidelines. So there's a separation there, and there should be a separation there. And there's reasons why this matters. The coding process needs to be protected. The coding process is so important. It's so far-reaching with its effects, and it's all tied to provider documentation. Highlights the separation between clinical judgment, operational requirements, and coding rules. Helps resolve disputes over coding versus payer clinical validation audits. So the bottom line then, we think coders have to adhere to the documented diagnosis. Clinical definitions or criteria are beyond the scope of the coding system. So it is a real important concept to consider. Next slide, please. Let's talk about sources for a couple minutes. Sources used to deny a diagnosis. You have a scenario, acute respiratory failures based on clinical information from coding clinics. It's not allowed. And when a payer uses clinical information, you really need to push back hard at this. Coding clinics are designed, if they have clinical information in them, they are designed to be used by coders to help understand the clinical situation. That is their sole purpose. It's not acceptable for a diagnosis to be denied based on information found in coding clinics, and vice versa. It's not acceptable for appeal writers to use that clinical information to clinically validate a diagnosis. So it works both ways. So we've got to consider that. And like Dr. Smith said yesterday, whenever we were going over this webinar, he said, I have yet to check a coding clinic to make sure I diagnosed somebody correctly. So I think that's a good way to look at it. Dr. Smith, did you have anything else to add to that?
No, I think you said it yesterday, which is, it's appropriate to use Harrison's textbook of medicine if you're going to look for a clinical diagnosis. It's completely inappropriate to use coding clinics to diagnose anything. Facts speak for themselves. You're looking for peer-reviewed, evidence-supported literature. Pick up a surgical textbook, pick up Harrison's, use that. But I've yet to meet a physician, nurse practitioner, physician assistant who would say that they got their education and judgment based on coding clinics. So if you have a payer using a coding clinic to try to justify a clinical position, point out the absurdity, reach for a textbook, reach for a peer-reviewed journal article, and swat it down quickly, like the cockroach it is.
Okay, next slide, please.
Personal opinion.
All right, and here's coding clinics have the actual verbiage that you need to prove why it's not appropriate. So they use coding clinics, push back at them with coding clinics, as well as the, what Dr. Smith just talked about, the peer-reviewed journal article or the textbook. So this coding clinic, users may continue to use that information as clues, not clinical criteria. Okay, next slide, please. And here's another one. Can background clinical information be used as clinical criteria for code assignment? No, it can't be used for that. Any clinical information published in coding clinics is provided as background material to aid the coder's understanding of disease processes. Done. That's it. Next slide. Okay, let's talk about queries just for a couple minutes. CDI professionals and coders gotta follow the ACDIS and HEMA's guidelines for achieving a compliant query practice. Make sure it's been updated at least once. Make sure that you have whatever was in effect at the time of the patient's dates of service, whenever you're going to use information from this article or from from these guidelines. So just going to concentrate on two things from these guidelines. When to query. Queries may be necessary, but not limited to the following instances. A, to support documentation of medical diagnoses or conditions that are clinically evident and meet UHDDS requirements, but the corresponding diagnosis or conditions are not there, are not in the medical record. Okay, we're obligated to query under that circumstance. And D, to seek clarification when it appears a documented diagnosis is not clinically supported or conflicting with the medical record documentation, clinical validation. So we are required to query in those conditions. So when you see them, you need to query. It can be hard in these circumstances. They're not always well received, but we need to do it. We need to find the right way to do it, and you can. It's very important. This is a huge prevention tactic, huge prevention, a preventative tactic for denials. So let's go to the next slide. I'm going to talk a little bit more. So don't forget, you need to query when it appears a documented diagnosis is not clinically supported. So here's some tried and true ways to get some physician buy-in for this whenever you're asking these tough questions. Get your physician advisor to help. I know not everybody has a physician advisor, and if you, especially some of the smaller hospitals, talk to your manager. If your manager can't, he or she should talk to their manager. It's that important. And if you do get the physician's ear, explain to them why the query was posed. So often they don't understand why you're asking the question. Explain it. Show the physician actual denials, PHI removed. And I can't tell you how many physicians I have shown actual denials to, and they were amazed. They had no idea that this was happening. And what works even more is if you have denials involving the physician's patients themselves, show that to the physician. They're taking my diagnosis away. It's a huge eye opener. And don't be afraid to link these denials to a decreased CMI, the hospital report card, and individual physician statistics. Use targeted education to drive those points home. Speak with department heads, get on the agenda for department meetings, and this information can trickle down. If it's important to the department head, generally can make it at least more important to those others in that department. Next slide, please. So let's just kind of wrap this section up just a little bit more about CCs and MCCs because they are so important in the denial and appeal world. So here's just a couple examples of a DRG without a CC or MC, have a decreased relative weight, a decreased expected length of stay, and just, baseline reimbursement. DRG with a CC, you're going to have an increased relative weight from that base DRG, increased expected length of stay, and the reimbursement will be more. But that's likely going to be targeted for denial, especially if there's only one CC. A DRG with an MCC, the relative weight will be increased even more. The reimbursement is more. The expected length of stay is more. The relative weight is more. And it's very likely to be targeted for denial, particularly if you only have one or two. So, because if they can knock out one or two MCCs, they have it, they'll be able to pay you less. And as Dr. Smith said earlier, that is their goal. All right, we're going to talk about some enforcement strategies here. Next slide, please. Okay, this is a Medicare Advantage case. An enforcement strategy is to appeal. So let's look at this. Would you appeal this or would you not appeal this one? Elderly lady with flank pain, nausea, vomiting, cough. Couldn't keep down much except popsicles. Had pyelonephritis, possible pneumonia. Baseline creatinine about 122, increased in the ED to 1.5. Started on IV fluids, IV cefepime. Diet was clear liquids as tolerated. Well-documented expectation for a 2-midnight hospitalization, IV fluids and antibiotics were ordered. The denial reason, inpatient status denied because there was no documentation of need for continuing treatment with IV antibiotics and or IV fluids. Well, hopefully most of you out there are going to say, I'm going to appeal that because yes, you want to appeal. Next slide. It's all about the expectation. Don't forget, this is Medicare Advantage. The expectation is what CMS has to be there, the expectation of a 2-midnight stay. She was nauseated with vomiting, had an infection, couldn't keep anything down, kidneys were negatively impacted already, needed IV fluids and antibiotics. As Dr. Smith likes to say, it doesn't really matter what happened after the order was written, though that information can help support that it was the right decision. But you want to look at everything that was going on at the time the order was written. What did that physician have to look at? The labs, the x-rays. That's how they made the expectation of a 2-midnight stay. And don't forget to address errors made by the payer. Let's go to the next slide, please. We see a lot of selective interpretation by MA payers. And so don't forget, if they have in their denial, an MA payer says they have to fail a period of observation. No, they don't. Must meet interqual, must meet MCG. No, no. Must exhibit any number of specific signs and symptoms. No, no, they don't. None of that is in CMS. But is it in your contracts? Got to check them. Next slide. Very quick guide to ALJ and external review processes. Next slide. Okay, this is a quick and easy graph. It shows you the different levels. If you have a traditional Medicare case, if it's a good, strong case, our recommendation to you is that you take it as far as you can. How many of you stop at a level 2? You don't go to the ALJ level. We strongly suggest that if it's a strong case, go that far. We we go to level 4 as well. There's a source there, gives you more information. HHS Primer, Medicare appeals process, gives you lots of good information. Next slide. The ALJ process. This slide has been updated for calendar year 25. You can also find that at CMS. I used to have this, I had it taped right beside my desk so I could look at it all the time. It's a good one. It's a good one. Explains the ALJ process very, very nicely. External review, commercial and non-Medicare Advantage. Usually have to exhaust internal levels of appeal. Different states might have different rules. Hospitals can be contracted or non-contracted. The key points, if the hospital is contracted with the payer, there's going to be binding decisions, but it is going to be a more streamlined and a predictable process. Not contracted with the payer, it's not going to be as predictable. It's not pre-negotiated. However, patient appeal rights are much greater generally than what the hospital has in these cases. So this is where you want to get an appointment of representative, paper signed, and then you can appeal on behalf of the patient. Let's go to the next slide. Okay, Dr. Smith.
Okay, so in the interest of time, I'm going to fly through some information here. Talking about the 2 midnight rule. What's that?
I just said next slide, please.
Oh, next slide. Okay, so we're going to dissect the 2 midnight rule. There are certain hard and fast exceptions to the 2 midnight rule. They're here. The big one is the CMS inpatient only list. It's updated every year. It changes. It behooves you to keep if you do get a denial about a procedure, check to see if it was on the inpatient only list for that year. As I said, it's reviewed and updated annually, and ideally, a critical compliance point is that somewhere in the record it should reflect that this is on the CMS inpatient only list. Further detail would be to document the needed care, the complexity of care that was provided during the pre and post-op period. Next slide. Common documentation pitfalls that we see with the 2 midnight rule: vague physician notes, templated notes. We see a lot of just star normal notes or dot normal notes with a normal exam, conflicting documentation that exists as a result of using templated notes. We've seen the pitfalls that come from lack of specificity, using the word acute, for example, to capture an MCC. I think regular feedback to physicians and CDI teams, as Karla had mentioned, is very, very helpful. Templates, plus minus, if it helps to improve documentation and accurately capture the severity of what's going on, that's great. Looking at your denials and those that are upheld that you're not successful with, and seeing if there's some documentation issues that those have in common, and then feeding them back to the CDI staff or your physician advisor for looking at strategies to improve would be beneficial. Next slide. Documentation gaps, a common denial trigger. So we'll often look at charts where there's a standard 2 midnight expectation statement that automatically populates in the chart, that I expect the patient's care to require more than 2 midnights just for that attestation. But there's really no description of why does a patient need to be inpatient. So looking at the difference between a patient coming in with chest pain and just being a little more specific about the nature of the chest pain. Patient's got unstable angina. They're at risk for arrhythmia as a result of ischemia. They need telemetry monitoring, nurse monitoring that's just not feasible or safe in an outpatient basis. Is the difference between being able to defend the chart and the inpatient stay and not being able to mount a defense. So I've always encouraged physicians, clinicians, when they are document, is to explain why. So if you're admitting to inpatient, the key question is, why does this patient need inpatient care, and why is it not prudent, safe for the patient to be in observation or outpatient status? So you need to just have them answer the why question, and you're fine. So appealing Medicare Advantage noncompliance, we're seeing a lot of pushback where Medicare has reminded payers repeatedly that the expectation of the 2 midnight rule will be equally applied to Medicare patients and Medicare Advantage patients. Go back to CMS guidance, the CMS fact sheet on the 2 midnight rule, Medicare benefit policy manual is clear, and it emphasizes 2 midnight rule, and it also gives credence to the physician's judgment in those admissions decision. But physician's judgment has to be documented. You can't extrapolate what they might have been thinking in their head. They've got to put it in the record, or it didn't happen. Next slide. Big fan. Our parent organization, PayerWatch, forever has been screaming from the rooftops about using the provider complaint process. So if you're working with a Medicare Advantage plan and you feel that they are acting unjustly, unreasonably, gather these things up and engage in the CMS complaint process. CMS is taking these things seriously. They will not get involved in complaints that say our bill is not getting paid. But if you have evidence, and it's best to gather 5, 10, 20 examples of something, bundle them up, and then take them to your manager or physician advisor to follow the CMS complaint process and submit them to Medicare. Medicare is actually taking significant notice of this. The quality, the star ratings for MA plans are significantly impacted by the number of complaints coming in, and they actually double weight complaints compared to the other factors used in determining Medicare Advantage star ratings. That can equate to millions or hundreds of millions of dollars in lost revenues for some of these plans. I've heard some discussion with other physicians physician advisors I work with, where they started filing Medicare Advantage complaints with CMS, and the medical director from the MA plan called them and said, hey, let's just keep CMS out of this. If you have any issues, why don't you just call me directly and we'll resolve this? Guess what? No. The answer is a nice try, but no. We're going to always, tell CMS what's going on, because CMS wants to know. They want to make sure that the beneficiaries are getting all of the benefits they're entitled to, and that means that they're getting every benefit that a traditional Medicare beneficiary would be entitled to. Next slide. Try to wind this down really quickly here. Why it's critical, as I said, accountability. It identifies patterns of unfair payment practices, such as delays or inappropriate denials. It ensures that MA plans are held accountable for coverage decisions. We want to make sure that somebody with a red, white, and blue traditional Medicare card, that if they elect to go into an MA plan, they're getting the same benefits. I did mention to Karla yesterday, as we're going through these slides, it's important to remember that there is a 6-month period when patients become eligible for Medicare where they can elect Part G, Medicare gap insurance. Medicare Part G provides for additional days in the hospital compared to traditional Medicare. It also provides copay coverage for your Part B and your Part A annual deductible. What happens when people sign up for an MA plan and then try to go back to traditional Medicare is they now have pre-existing conditions, and those pre-existing conditions will prevent them from signing up for Part G plans if not elected in that first 6-month period. So there's a lot of people assume that if I don't like my MA plan, I'll just go back to traditional Medicare and get a Part G plan to cover the financial out-of-pocket. it just doesn't work that way, folks. So we need to make sure these plans are accountable. We need to make sure there's transparency, and the only way you're going to do that is by reporting infractions of the rules to the federal government. Next slide. How to file. CMS has a complaints portal. The American Hospital Association and your state hospital associations have the documents if you want to reach out to them. Those are the best resources to get the document and fill them out. One of the attorneys that I work closely with, Rochelle Martin, who is in Kansas. Ms. Rochelle, if you're listening, and yeah, you are in Kansas, is a big fan of using a pre-populated form. So she's taken the form, run it through Microsoft, and has pre-populated most of the fields. It makes just adding in the facts very simple and really improves the efficiency of getting these things over to CMS. She actually did a webinar a while back talking about this process. If you want to take a look through either the PayerWatch website or the Adam website, I think you'll find that webinar, and you can listen to Rochelle talk you through how to do this and the benefits of doing this. This was within the last 6 months, so that's a really good webinar to go back and review and learn that skill. Next slide. So CMS has underscored the 2 midnight rule and has reminded MA plans that is January 1st, 2024, that they essentially have to behave as traditional Medicare. The policy requires that inpatient admissions are generally appropriate for Medicare Part A payment if the admitting physician expects a patient to require hospital care spanning at least 2 midnights. I know one of my colleagues, Reggie, is listening to me. We've had Reggie on before. He is brilliant at pointing out that just putting somebody in as an inpatient for 2 midnights does not necessarily count. They actually have to have things going on. So if somebody comes in with unstable angina on a Friday night and your cath lab's not open till Monday morning and they're sitting there Saturday and Sunday, eating breakfast, lunch, and dinner, and just sitting on a telemetry monitor waiting for a cath on Monday morning, that is not appropriate for inpatient care. They could have come in on Thursday and been cathed on Friday and been home. So that, just because you have the inconvenience of a weekend and a closed cath lab, does not meet the medical necessity of the 2 midnight rule. There has to be a presumption that they are actively going to be getting care during that period. This was then just re-emphasized as well, that the MA plans must adhere to the inpatient admission criteria outlined in Title 42 Code of Federal Regulations, which includes a 2 midnight benchmark. Are they necessarily doing it? No. They'll push back. They'll use their own criteria, and this is somewhat of a gray area. But this is an area. What you're going to find is your 1, 2, and 3 day Medicare Advantage stays are going to be looked at very closely, and a lot of these are going to be denied, and you're going to get into arguments back and forth about whether they truly needed inpatient care. So you need to clearly identify the patient's risk, intensity of service, and severity of illness. To use Interqual's terms, you need to, hopefully you've got great physician documentation that describes the why. If you don't have the why, you really don't have a great basis to appeal these short stays, but hopefully the why is there. Next one. So the OIG has come out at this. The OIG's also come out and said that we're going to start to look at short stays. So, you know, this is being looked at on both sides of the equation. I think the take-home message is that Medicare is really paying close attention to this. We'll see it continue to be an area of focus and probably disagreement going forward. So the extent that you can develop really good templates, language, work with your clinicians to get appropriate documentation in the chart, you're going to better position your organization to defend itself with these short inpatient stays. Next slide.
Okay, we want to thank everybody.
Yep.
Dr. Smith, thank you so much. Lots of good references here for you. Next slide, please. Okay, I'm sorry, there's not time for questions and answers today.
We will collate your questions and we will respond to them by email. So and if need be, we'll provide references and not personal references, but professional references related to your questions if you need supporting evidence. But we really do appreciate questions. I also would ask anybody listening at this point to email us with issues that we might help address through future webinars. So if there are particular topics that are of interest to you, if there are new types of denials that are coming across your desk, if you're getting into payer challenges that are new and different territory than you're used to dealing with, we have attorneys, we have coders, we have Karla, we have me, as well as a number of other physicians, and you are experts that can pull webinars together to provide education and even answer single questions. So we want this to be a community and an ability to exchange information, best practices, and continue to grow.
Thank you. One more announcement. Our next webinar is going to be February 26th from 2 to 3 Eastern. And it's going to be a two-parter, just one day, but two parts. The first part's going to be on emergency department level of care. And the second part's going to be clinical validation of acute CHF in the TAVR setting. So don't miss it. Something for everybody. All right. Thank you again, Dr. Smith. Thank you all for attending. We appreciate it. Bye.